Good evening. You're watching Dr. KK's Med Talk non-stop shows. Welcome to Med Talk Live, conversations that matter, an educational initiative supported by LA Lilly. I, Dr. Surendran Dhanasekaran, am your host for today's session. Over the last few years, obesity management has undergone a remarkable transformation beyond lifestyle intervention and bariatric surgery. Newer pharmacological therapies have emerged that target the biological pathways regulating appetite, satiety, and energy balance. Among these innovations, dual agonists have generated considerable excitement because of their ability to achieve clinically meaningful weight loss while improving several metabolic parameters. Clinical studies have demonstrated weight reduction approaching those previously seen only with metabolic surgeries, marking a significant shift in the treatment landscape. Today, we will explore what dual agonists are, how they work, who may benefit from them, and how they fit into the broader framework of obesity management. Here are today's key updates on obesity. Recent reviews suggest that GLP-1 GIP dual agonists have established a new benchmark in obesity pharmacology, with weight loss outcomes significantly exceeding those achieved with older anti obesity medications. The dual action of GIP and GLP receptors provides benefit on both glucose regulation and appetite control, making these agents particularly valuable in patients with obesity and type 2 diabetes. WHO recently issued guidance supporting the use of GLP-1 based therapies as part of the comprehensive obesity management strategies. International guidance now emphasizes long term medical management of obesity, similar to hypertension or diabetes, rather than a short term weight loss intervention. Several next generation agents, including triple agonist and amylin based therapies, are currently in development, signaling continued innovation beyond current dual agonist. Let's go to the topic of the day. Now, let me introduce you to our guest for today, Dr. Salam Ranabir. It is my privilege to introduce Dr. Salam. Dr. Salam Ranabir, one of India's most respected endocrinologists and academicians. Dr. Ranabir is DM Endocrinology from All India Institute of Medical Sciences, New Delhi, and currently serves as professor and head of the Department of Endocrinology at Regional Institute of Medical Sciences, Impal, Manipur. He is also a fellow of the American College of Endocrinology. With extensive clinical, academic, and research experience in endocrinology, diabetes, obesity, thyroid disorders, and metabolic diseases, Dr. Ranabir has contributed significantly to advancing endocrine care and medical education in India. He is widely recognized for his work in obesity and diabetes management and has been an invited faculty at numerous national and international scientific forums. We are delighted to have him with us today to share his expert insights on evolving role of dual agonists in obesity management.
Thank you for the kind introduction.
So, so what are the dual agonists in simple terms?
So, in endocrine, we deal with hormones. Like insulin is a hormone secreted by the pancreas, and another that is insulin a hormone secreted by the glucagon. There's also secreted by the pancreas, and like that, there are many hormones secreted by various endocrine glands like thyroid, adrenal, gonad. So these hormones they are released in the bloodstream and from the endocrine glands, and they reach the target tissues or organs where they act on certain receptors. So dual receptors means they act on two receptors so that the function of the hormones is additive. So single hormone will have some effect, but if we combine two hormones, there will be additional benefit on the patient. So we get a better response compared to a single one. So when we are talking about obesity, currently we are what is available in the market and what is internationally used now is the dual GLP-1, that is glucagon-like peptide 1 receptor agonist, and GIP, there's a glucose-dependent insulinotropic polypeptide agonist. So these two hormones agonists for them have been developed, and this biologically synthesized drug they combine act on these two receptors, producing significant benefits in terms of obesity and diabetes.
And how are they different from the older weight loss medications, sir?
Uh, when we treat patients with obesity, we call the program to be successful if the weight loss is around 5%, minimum weight loss of 5%, and various studies have shown that if a patient can achieve weight loss of at least 5%, there are benefits in terms of blood pressure, in terms of blood glucose, and other metabolic parameters. But the older generations of drugs, the benefit weight loss reduction that is seen is hardly 5 to 10%. If the patient is lucky enough, maybe 10%. Generally, it's around 6 to 8%, and mm, so the patients are not that happy with the response. So the newer generation, this group of drugs like the GLP-1 receptor agonists and the dual agonists, they are very very powerful. For example, the dual receptor agonist, which is also known as the tirzepatide, what is available in the international market as Monjaro or Zepbound, it can reduce the weight to the tune around 20%, which is almost as close to the weight reduction achieved with some of the older versions of bariatric surgery, where it's around 20 to 25%. So the response is much more tremendous compared with the older generation drugs, where the weight loss is hardly 6 to 8%.
So, which hormones do the dual agonist target?
So this GLP-1 and the glucagon-like peptide 1 receptor agonist and the glucose dependent insulinotropic polypeptide agonist, they target two hormones. That is insulin. They stimulate the insulin secretion and inhibit the glucagon secretion. In type 2 diabetes, we all know there is uh, increase in glucagon secretion, and at the same time there is increasing insulin secretion is not up to the extent that is required by the body, or even if the secretion is there is insulin resistance. So these two agonists work on the receptors, and it works mostly on the GIP receptor, and it stimulates the insulin production and decrease glucagon, thereby it improves the blood glucose and and by working through the GIP receptor, it also improves the metabolism of the fat. So mainly they target insulin and glucagon.
Okay. So, why are they considered as a breakthrough in obesity care when compared to the previous drugs? Because there have been
So
so
as
many drugs in the market for obesity, but none of them have been successful. But you suddenly see a big race. Now,
yeah,
suddenly, we talk about these two drugs, GLP and the other one, which is a dual agonist, GLP plus GIP.
yeah, as I highlighted earlier, most of the drugs are not that powerful because, for example, one of the popular drug that was used in India was orlistat, which inhibits the intestinal absorption of fat. So the effect is not that great. It may be around 6 to 8% weight reduction, and there are certain issues with this because it can lead to fecal incontinence. Oily stool leakage can be there. If the patient is not adapting to the dietary modification, if they continue to take a lot of fat with this drug, there'll be leakage of stool, and there'll be abdominal cramps. Even there can be kidney stones also. Oxalate stones can also be there. And mm, there are other issues, like for example, other drugs like the what is used is an your pentoramine. They can increase the heart rate. There can be even suicidal tendencies. We have issues with some other older drugs, like rimonabant at one time was popular. There was suicidal tendency, so it was not used. And this phentermine cannot be used in patients with uncontrolled hypertension. And there topiramate is another drug which cannot be used in patients with history of seizures. So all those major side effects are there, like they can produce dizziness, drowsiness, all those issues are there. But so these older drugs are not that powerful. At the same time, they produce many unpleasant side effects which the patients are not compatible with. The new generation of drugs, they are quite powerful in terms of weight reduction, and the amount of weight reduction is so robust that there can be even reversal of diabetes mellitus. So patients, if they can lose weight by around 10 to 15% from baseline within 5 to 6 years of diagnosis of diabetes mellitus, there can be reversal of diabetes mellitus, meaning they can be off all the diabetic medications for several years. Even they can be off the BP medications because of the good benefit in terms of blood pressure, also by lowering the body weight and also by its effect on the blood vessel. So, and others, and a beautiful thing about this drug is that the side effects are mostly GI side effects, means related to the gastrointestinal system, like nausea, vomiting, constipation, uh, maybe diarrhea, and we don't have any major very serious side effect. Very serious side effects with these drugs are very, very, very rare, and they are very powerful with minimal side effect. That's why this drug has become so popular. If I remember correctly, in India, within its launch, within the first 6 months, it came a 100 crore brand.
So, how effective are them when compared to the traditional therapies for weight loss?
A traditional therapist, as I've been telling again, because the first for weight loss, the first thing what we usually advocate is lifestyle modification, diet and exercise. Okay, I would like to spend some time because we always say the patient to do exercise, but exercise alone is not enough to reduce weight, because various studies have shown that to reduce weight, there should be a calorie deficit of at least 500 to 750 calorie deficit, either from the diet or patient has to burn up that much amount of calorie
Calorie.
or energy has to be they have to spend. To spend 500 calorie, a person have to walk at least 7 kilometers per day, which is will be virtually impossible for a morbidly obese patient. They will not be able even to move for 100 meter, 200 meter, maybe even difficult for them initially. And the dietary restriction, it's easier to preach than but difficult to practice, because we human being, I like to stress again, we enjoy food. We don't eat
Yeah.
protein, fat, carbohydrate. We love food. We enjoy the taste of food. And there's something called hedonic eating reward system. That's why we love the food which tastes better. Like the fast foods, we like it better because they taste better. Otherwise, for survival, if we can take protein, carbohydrate, and supplement, that may be enough. But nobody will be able to survive with that, because that doesn't taste good. So we want enjoy the taste of food. So asking the patient to restrict food to a lot of restriction is difficult, but if we advise properly, the portion control, it may be better for them to follow. And even studies have shown that with dietary motivation alone also, the weight reduction is hardly 5 to 6%. Maybe if they're very good, doing very well, my 5% weight reduction. And with the older generations, like those drugs were highlighted earlier, early stage weight loss is around 5 to 6%. With um, penteramine, it has been approved for long-term use because of the side effect, like increase in the heart rate, increase in blood pressure. Though combined with another drug that has been approved, but in India it's not used. In India, what is currently available and approved is orlistat, liraglutide, semaglutide, and this tirzepatide dual agonist. And these dual agonists, they are so powerful. The weight reduction with even the low dose of this drug by 5 milligram is around 15%. With the maximum dose, if the patient can tolerate, with 15 milligram, the weight loss has been seen to be around 20% average weight loss. But some of the patients even lose weight more than 25% in the studies.
So, are they injectables or oral medications?
Currently, the dual agonists are injectable, and but the advantage, the beautiful thing about this group of drug is that it can be injected once weekly, not daily injection, which nobody likes, because injection is something which nobody likes. People are happy, ready to take pills. Pills counts countless number of pills, but nobody likes injection. If we say insulin, people, I have seen people literally cried on my examination room when we say let's start insulin. So there's a needle phobia or maybe insulin phobia is there, but these drugs once in a week with a very short needle. But what we have to do is we have to gradually build up the dose from a low dose once weekly, increase every 4 weeks to the maximum tolerated dose. So it maximum approved dose is 15 milligram, but various studies have shown that we need not go for the maximum dose also. But what is maximally tolerated by the patient, if it is crossing more than 5 milligram, it should give a good response. By 5 milligram, around 15% weight loss has been seen.
So, what are the major side effects in your practice?
So the major side effect, as I highlighted earlier, is mostly the gastrointestinal side effect that is related to, it will be nausea, because these drugs, how they work is they decrease the appetite, they decrease the craving. So if we start at a higher dose, there will be definitely nausea. Patient can land up in the emergency with nausea and vomiting. So that is a major side effect: nausea, vomiting, constipation. There can be some diarrhea. Otherwise, there are very very rare side effects like medullary thyroid carcinoma has been reported in animal studies, but in human studies there is no such report. But as nobody is going to take a chance on that, that's why in a patient with family history of medullary thyroid carcinoma is not yet approved. Otherwise, in terms of other major side effect, pancreatitis, it's still debatable. There are some studies which have shown that there is slight increase in pancreatitis. Again, it's debatable. Many other studies that many other people are telling doesn't cause, but still, if if the patient develops pain of the man while on this therapy, we need to stop the medication and evaluate for pancreatitis. And so these are the only serious side effects. But most of the side effects are mild and can be tolerated by the patient if the patient can follow the dietary modification and follow the dose schedule. Go slowly. There's no hurry in using this drug. If they are aggressively titrating the dose, they can land up in trouble with nausea, vomiting.
So, who should we consider for a dual agonist therapy, in your
In
view?
India, as far as the approval by the Central Drug Committee is that any adult with with BMI more than 30, this drug can be used, or those with BMI more than 27 with any obesity-related comorbidities like hypertension, diabetes mellitus can also be used. And this drug can be used in patients with type 2 diabetes. Actually, this drug was developed for the management of type 2 diabetes. But in the studies, it was found that there is weight loss with this drug as a side effect. So taking advantage of the side effect of the drug, it has been used as an anti-obesity medication. So any patient who is on type 2 diabetes uncontrolled, and with the recent guideline for the management of type 2 diabetes is that any patient, irrespective of the baseline blood glucose, if the patient is having history of atherosclerotic cardiovascular disease, the recommendation is to start a GLP-1 receptor or dual receptor agonist, which has got a proven cardiovascular benefit. So blood glucose control is not the important thing now, though it is very important, but which drug we are using and controlling the blood glucose is also very very important now. So in patients with heart failure also, this drug, we have studies have shown that they are beneficial in patients with diabetes and obesity. And in terms of kidney also, it can slow down the renal failure. That's why this drug can be used in such patients with diabetes, with comorbidities like atherosclerotic cardiovascular, meaning heart attack, stroke, or those having chest pain, shortness of breath, then any patient with kidney failure, patients with, even there are studies showing that it is beneficial for the fatty liver disease, a simple layman's term called the fatty liver disease. And in US, it has been approved for the obstructive sleep apnea, where patients snores a lot at night time, and the apnea hypopnea index, the snoring has been improved by the use of this drug. But in Western countries, it has been approved in people below above 10 years, but in India, as of now, it is approved for only people above 18 years. So we have to restrict our prescription as of now.
So, can they help patients with diabetes and obesity together?
Yes, yeah, definitely. Because this drug was initially
Started
studied
for
started as a
obesity.
drug for type 2 diabetes. Then this all these GLP-1 receptor agonists was started as a drug for type 2 diabetes. GLP, and then dual agonist is also started. First studied as a drug for diabetes. It showed good benefit, A1C reduction of 1.5 to 2, almost, even some of the studies more potent than insulin. Insulin should be the most potent drug, but in studies, why it was more potent is because insulin can cause hypoglycemia, low blood glucose, which is one of the limiting factor in the use of insulin. The beautiful drug, this beautiful drug doesn't cause low blood glucose. That's why those can be titrated without any fear of hypoglycemia, which is one of the limiting factor in our management. And these studies have shown that they also produce weight loss. That's why it has been studied as an anti-obesity medication and found to be very, very powerful. So it is beneficial in patients with or without diabetes, in patients who are obese, and in patients with diabetes. They are one of the most powerful agents for controlling the HbA1c, blood glucose, and other associated comorbid conditions like dyslipidemia. The studies have shown that It can reduce the triglyceride to around 24%. It can reduce the blood pressure by around 6 millimeter mercury, and increase the LDL, uh, decrease the LDL. So there are many good things about these drugs.
So, how quickly do you see the results in these patients in terms
Initial
of
fast.
weight loss and in terms of reduction of HbA1c?
HbA1c, let me answer the first HbA1c part first. HbA1c is being a measure of the average blood glucose in the last 3 months. So we'll not be seeing response very quickly. So we'll be seeing by 2 to 3 months, because there will be carryover effect of the high blood glucose that was there before. So though the last 1 month is the most important one in the calculation, but then there will be carryover effect. So we'll see the good response by around 3 months, but we'll see the reduction in fasting blood glucose by as quickly by around 2 to 3 weeks. Fasting blood glucose will drop because of the decrease intake, decrease in inflammation. In terms of weight loss, the first 1 week, where is the it is I won't say it is it will produce a significant effect, because it'll be just for the body to adapt to the drug we are giving with a low dose. For tirzepatide, a dual agonist, the 5 milligram, meaning we will be reaching the full dose of 5 milligram by the end of 2 months. So by around 8 weeks to 16 weeks, we'll start seeing the measurable change in the body weight, and the maximum body weight change is usually seen by around 60 to 72 weeks. In most of the studies, by 60 weeks, 72 weeks, the maximum weight response can be seen. But as early as 8 weeks to 12 weeks, by 2 to 3 months, they will see some mm, measurable change in the weight.
So, are these drugs safe for a long term use?
As of now, there are more than 2 year studies, and it has been shown to be quite safe. And obesity, we all know, for a very long term studies are not there as of now with obesity. So, and this drug has not been in the market for not that long. So, we are talking about a very long term, 5 years, 6 years data. We don't have that much robust data. But obesity, what we should remember, is a chronic relapsing disease, because studies have shown that once we stop the therapy, by around 1 year, two-thirds of the weight loss will be regained. So it has to be continued unless the person can strictly follow the dietary regimen modification and do exercise sincerely. They will regain the weight. There is no way out. So it has to be continued for a long term.
So, can the dual agonists reduce food cravings
Yeah,
compared to
yeah.
the?
It will reduce the food craving, because it works on the um, through the dopamine pathway. Also, it reduce the uh, desire, the pleasure of eating will also be decreased, and studies have shown that it decrease the craving for fatty food, for the fast food, and sugar containing food. Or even there are even reports that it can reduce the craving for alcohol also.
Okay. So, do they have an effect on the metabolism beyond the appetite suppression?
Yeah, as I've already mentioned, it also reduced the triglyceride to the tune of almost 24%. And there are some data that it can activate the brown adipose tissue. In human being, brown adipose tissue comprises a very small percent, less than 0.5% of the body weight, and it is mostly around the neck and the upper torso. And there are studies which have shown that it can modify the white adipose tissue to the brownish adipose tissue, and
Burning
uh,
of fat.
brown adipose tissue helps in better utilization of the calories. There will be more burning of the calories, so person can lose weight. And there are benefits in terms of uh, blood pressure also. So around 6 millimeter mercury reduction in blood pressure also, and it can also re- remove out the fat from the liver. So fatty liver also is improved. So not only it is just reducing the body fat, but it's also improving other parameters like the cholesterol, blood pressure. But one thing we need to remember, what I look to highlight, is that the persons have to eat a lot of protein when using this mm, group of drugs. Otherwise, because of the poor intake, they will lose not only the fat mass, but there also will be some degree of muscle loss. So there has to be good protein intake, at least 1.1 to 1.5 gram per kg per day. Protein intake should be there minimum, and there should be resistance exercise, means weight bearing exercise, or with the using the body weight like push up, pull up, whatever, or using the resistance band at least 2 to 3 times in a week. Weight bearing exercise also is to be done. Otherwise, studies have shown that out of the 100% weight that is lost, 80%, 85% will be from the fat, and 10 to 15%, or up to 20% maybe from the muscle mass. And once muscle mass is lost, it's very difficult to regain the muscle mass unless person do a lot of physical activity. So to prevent or reduce the at least the reduction in the muscle mass, high protein intake, and weight bearing exercise, whether with a resistant band or using the body weight, has to be done.
So, are they affordable and accessible?
In terms of accessible, it is freely available in India. Even in my part of the country, a small town in a hilly state where the communication is not that great. Even it is available in my part of the country, I'm also using this. Only thing is a bit costly as of now, because it is not top level. It is marketed by Eli Lilly or co-promoted by Eli Lilly along with Cipla. So the price is the only major issue as of now, because the 5 milligram, lowest dose 2.5 milligram will cost around 13,000 per month, and the highest dose 15 milligram will cost around 25,000 per month. So price is a big issue in in resource limited places like small towns, and maybe in big cities, metros, where a lot of rich people are there, they can afford. But affordability in small towns like ours is a little bit of issue. Otherwise, the older generation, like the single agonist, GLP-1 receptor agonist, his price has been reduced drastically after the up level. But this one, it will take some time, because up level, to be up level, it will take minimum 15 years. There's a usual time period for the patent to be off. So we have to wait till then. Price as of now is a bit on the higher side. But if we look at the economic part, another thing is that by reducing the weight, patient can reduce the, maybe as I said earlier, patient can be off the diabetic medication, or they can reduce the dose of diabetic medication. They can reduce the cost of reduce the BP medication. So if they cut down the price of that, then the total price actually comes down.
Yes. So, what should the patients discuss with their doctor before starting this drug?
So if this particularly start with a female patient, if the patient is a female, then they are not supposed to conceive while on this drug, because animal studies have shown that there can be some harmful effect on the baby. So there's and they should not conceive for at least 3 months or 2 to 3 months after stopping the therapy. Or if they are using contraceptive, they should be increasing the dose of the contraceptive for 4 weeks, or every time when the dose is increased, because with the slowing of the gastric emptying, the absorption of the contraceptive also can be impaired. So they need to use another method of contraception, maybe the intrauterine device, or they go for the condoms. Another thing is, if there is a family history of thyroid cancer, like medullary thyroid carcinoma, though it's an uncommon type of thyroid cancer, not that common. The commonest thyroid cancer is papillary thyroid carcinoma. Around 80 to 90% is papillary thyroid carcinoma. Medullary thyroid carcinoma is an uncommon type, but animal studies have shown that there is chance of medullary thyroid carcinoma, but not yet established in humans. So if there is a family history of those things, they should not be using. Any history of pancreatitis is there, then they should not be using this drug. So what are the possible side effects? What are the possible harm? What are the benefits? Patients should be very thorough with that, because without knowing the benefit, without knowing the harm, it's not advisable to start taking any medicine. I remember my teacher during my postgraduate long time back, he once told me, if you don't know the side effect of a drug, you have no right to prescribe the drug. I truly believe in that. Whether you know how the drug works or not, mechanism, this for economic purpose, with how it works or not, it doesn't matter to the patient, but side effects matter. And the patients also should know the side effect, and we should be ready to tackle the side effect of the drug. And notice the appreciate the side effect and tackle the side effect. So benefit and the side effect they should discuss, and how long they can continue. That's also important. The price factor is also an important because no point taking for 1 month or 2 months and stopping because you won't get hardly any benefit out of that. So price has to be taken for a long term, at least for several years. Maybe after that, if they are comfortable with the new dietary modification and they can do the lot of physical activity, maybe the weight regain can be cut down, but still there are chance of weight regain. So all those issues has to be discussed.
It was great. It was great for you to give so many insights about the drugs. So thank you, Dr. Salam Ranabir, for joining us for today. This will be all for today. Dr. KK's Med Talks will return tomorrow at 7 p.m. with another edition of the show. Keep watching Dr. KK Med Talks. Namaskar. Thank you. Thank you.
Thank you.